recording tonight's, mostly for the sake of the chance to put it as on-demand content for others, or to, yeah, basically just let people be able to take advantage of this who maybe couldn't log in tonight. So again, I'm going to go ahead and get us quickly there. I've had the Ove Peters bio up there, so hopefully you've looked through that, because we're going to move pretty quickly now into his presentation. Again, I'll just remind everybody we've got a neat experience tonight. The map on screen represents almost everyone except for some really angry people in Boston I neglected to put, but we have people attending from all the different states you see there, and even some people have been typing in, which is exciting. So the setup tonight, as you should know by now, is that we have many rooms of endos that are hosted by our Dentsply reps, and then a lot of different people who have actually registered and logged in on their own. So we've got a little we've got a mix, kind of a mishmash of our audience, Dr. Peters, where you've got some rep-hosted rooms, which are neat, and then you've got some individuals. So I would imagine you may see questions flying from all kinds of angles by the time we get to that. So without further ado, I don't think there's anything else I need to remind, except one more time, if everybody who did choose to use the phone, please be sure to mute your lines so I don't have to come in and do that, or even have to kick out or something. We wouldn't want to do that. So keep your phone lines muted for those that have dialed in that way. And I think I'll go ahead and you will see very soon in this next layout a Q&A pod pop up, and that would be where you can type in any questions that you have now or throughout the program, and we'll mostly save them to the end unless I feel like some of them are something that need to get addressed very quickly. So in which case I'll make it notice to Dr. Peters. So let's go ahead and switch over to presentation mode. There's the Q&A pod for any of you who want to type those in, and I think we're in good shape.
Yeah, thank you very much, John. It's a fabulous thing that we're doing today. As you know, I like to do innovative stuff, and this seems to be as innovative as it can be as far as webinars go. So, ladies and gentlemen, in the distance, it's always a little bit interesting to do that, just sitting in front of the computer, but without seeing you. I would like to thank you very much for showing up. This is phenomenal. This is an exciting stuff for me, as I said, for me to do, and I hope I can convey a little bit of the excitement to you. You're seeing in the background my very Germanic, unpretentious office, so don't be too worried about if I just move this aside a little bit. Because I want to talk about something that I believe is important going forward in endodontics, and that's preserving what matters. And I will tell you in the brief period we have together today why I think this is important. And let's start out with the substance of it. This is what happens sometimes, not as drastic as in this case. This is a couple of years ago, as you can see, in 1997. A colleague of mine was placing these pretty solid posts in these two teeth because the plan was to extract that first molar, which is what they did. Only to see that the situation was not ideal. As you can imagine, with this type of cantilever, you're setting yourself up for failure. This is drastic, as I said, and gets more drastic when the tooth is being extracted. What's the alternative? Well, not much, because you couldn't even place an implant. This tooth is not as good in anchorage. And it serves to show that just putting a post in like that or putting a build-up in like this is not going to be helpful. We do realize that posts do not reinforce teeth. We do realize, or at least we should realize, that removal of dentin, imagine how much dentin is remaining here. If you see this three-dimensionally, there's a whole lot of cross-sectional reduction. Removing dentin is predisposing teeth to fracture, and that is key to endodontic success. Let's examine the literature for a moment. Now, this is a recent paper out of Thomas Quist's group in Gothenburg, Sweden. And this is new, 2015, but the findings themselves are not new. And if you look at it from an outcomes perspective, if we have time, we talk about outcomes a little bit. Look at it from an outcomes perspective. What is really the key reason why teeth that are root canal treated, why are these teeth extracted? What they show in this paper is this. You got to imagine that in Scandinavia, and many of you know that, patients have to submit themselves to a government-controlled healthcare system, which is good and bad. And we cannot cover this topic, but for us it is good, because in this case they have a patient database of about 10,000 patients, and they can just track these patients over, in this case, 10 years. When they take a random sample, which was reported in the JOE earlier this year, when they take a random sample, representative sample of 420 teeth, they find a 10-year survival of about 82%, which is on par, if not a little bit lower than we have seen in other studies. Out of the teeth that were extracted, the ones that didn't reach the 10-year survival, endodontic diagnosis were only associated with 5 of the extractions. A very small fraction of the teeth that are in this study will get lost, will be removed by a diagnosis of persistent apicopathosis. By far, the majority of the teeth were extracted for fractures, for recurrent decay, non-restorability, and things of that nature. So we have to be mindful, what are actually the reasons why teeth in the long run are not serving their purpose. This is what we want to do. We want to have teeth for a lifetime. What we have done in the past is we have tested teeth for structural strength in a very simplified way. You all have read this paper, and maybe you all remember it vividly. This is Harold Mess's work. Peter Ray is the first author here, the other author. And we are looking at fracture strength. In this case, the unaltered tooth has a fracture strength of 250 kilograms. That's on average here. And why is this important? Well, because this is not the load that actually occurs during chewing. We have not done a great service for our patients in analyzing this. A gold only shows fracture resistance of much higher values, so we think that just restoring a tooth with the cuspal coverage situation will create a very strong tooth. In reality, and I don't want to, this is not an exam obviously, in reality, physiologic biting forces are in the range of 50 Newton, 5 kilogram, not 500, 5. Parafunctional forces in the posterior dentition, 500 to 700 Newton, that is 50 to 70 kilograms, that is about here. So teeth do fracture, but they don't fracture the way this is modeled in this investigation. Many investigations are still doing the same thing. We have to be more concerned about fatigue mechanisms, and fatigue mechanisms respond both to the amount and to the structural distribution of radicular dentin, and of course coronal dentin as well. So in the future, we have to be more mindful where exactly dentin is removed. So this paradigm intrigues me, and going forward, we have to pay much more attention to more sophisticated in vitro and to clinical outcome studies. That just as a preface to where we are with this. And as I just said, typically fracture limiting the lifespan of a tooth occurs in a fatigue type manner. Impact fracture is possible, but it's a rarity. For those of you who have observed teeth and have done lateral compaction, it is not very frequent that you notice an overt fraction at the moment of compaction. Vertical, the same way, fracture could occur, but that's not typical. In fact, fatigue will set on over time. In the consequence, in the US and in the literature, the few studies that systematically look at restoration of root canal treated teeth, cast restorations are preferred. Because of studies, the ones that I showed you, but also because of the few outcome studies. I want to mention Aquilino and Kaplan in 2002, where they compare large amalgam restorations and cuspal coverage with gold crowns. The evidence in total is not very strong for either of those restorations, but I think at this moment, outcome studies would favor cuspal coverage. What is being noticed in a variety of studies, and I will come back to this point, is that dentin geometry, structure, and amount are predictors for restorative outcomes. When I say structure and amount, we have to read carefully engineering type of literature. So in this case, this is Dwayne Arola's group, who is now in Seattle, Washington. What he looks at is dentin in fatigue mechanisms. When you appreciate the SEM images on the lower right of this slide, this is crack propagation in dentin. In a magnified slide, what you see here is that the crack stopped at some point. There is some propagation in this direction, but a new crack develops this direction. Dentin has a built-in fracture propagation stopping mechanism. So the type of dentin, the way the dentin is laid down in a regular pattern is important. But equally important is the bulk amount of dentin. And we talk about this a little bit in the paper that you see on the left of your screen, where we say we want to challenge some prevailing paradigms. And one of the paradigms is that we're really preoccupied with looking at the periapical rigid lucent area and the disappearance of this as an outcome in endodontic treatment. When we look at what we have done, we have enlarged apically, and I'm sure we have, I heard that from John Crouch, that we have maybe 100 or maybe even more endodontists on the phone. We have enlarged apically to a varying degree. Nobody knows specifically what apical size is most conducive to even just having irrigation effect. And we draw our information from a variety of sources. I read a lot of literature, and among them I read this one here, out of a German group a couple of years ago, Journal of Endodontics, and they conclude that increased apical enlargement beyond size 25 in this particular study in curved small caliber canals, mesoroots, and lower molars resulted in unnecessary dentin removal without complete apical shape. Let me walk you through this diagram here. We have micro-CT slices, M2 preparation here, nickel titanium hand files here, and pro-taper. They kind of shoehorned these files in apical size 25, 30, 45, and 50. Not exactly accurate, but still a comparison that is possible. When you appreciate the green original canal anatomy and the red after canal preparation, it is evident that in particular the two engine-driven techniques here on the top and here on the bottom don't prepare any more quality shape already starting at size 30. There's two major things that we achieve by canal preparation. We scrape or somewhat treat the canal surface, and we provide enough space for irrigant turnover. The irrigant turnover is not addressed in this study, certainly not directly, but the canal wall machining or canal wall preparation is addressed. And there's no gain beyond size 25 in this type of canals, small caliber canals and lower molars. If you read the literature in its entirety, there seems to be a consensus that there is a sweet spot somewhere. We just don't know exactly where it is. My personal sweet spot is where I can bring a small irrigation needle, a 30 gauge irrigation needle, close to working length. And that is the case somewhere here in the range of size 25 or 30, depending on the taper you're using. I will come back to that point. When we consider the literature, there has not really been a good investigation, even in vitro, if any type of change that we make in terms of conservative preparation, conservative axis preparation, and so forth, will result in an improvement, except for this paper. In all its weaknesses, and it has certain weaknesses, this paper shows at least that conservative access results in a high resistance to fracture. But in this case, and they show the reduced or conservative access here, it resulted in an inferior canal preparation result compared to a traditional access. And that's very simple in molars, right? That's very simple to explain because they didn't prepare this access very wisely. They should have appreciated the distal canal and the buccolingual extent of the distal canal by preparing a little bit of a notch here, and they did that nicely for the mesial, but didn't do a good job in the distal because the extent is almost as wide as the extent of the two mesial canals here. Let me show you why I say this in a bit, but first let's discuss what the benefit is. If you prepare a small axis like this, and granted, that is not possible in quite a few teeth, obviously, because many teeth come in already with a much larger axis cavity or have a crown prep or deep restorations or large caries and so forth. But if you start out with this paradigm, we want to make sure that we understand this, the ramifications well. So if you have a small access cavity as opposed to a large access cavity, the structural strength is retained. This slide only shows that the amount of dentin is significantly different, that is removed. That's the target of the study. And when you look at the structural strength, the amount of dentin doesn't play too much of a role in anteriors. Incisors behave very similarly regardless of what axis you prepare. In premolars, the situation is different. There's a significantly higher resistance to fracture with the conservative axis. Traditional axis is problematic in small size premolars. The canal shape is actually as good as anything if you have a small conservative axis cavity in premolars. First take-home message, premolars, be very careful and very conservative with the axis. In molars, again, we have a significant difference in favor of a small axis cavity, almost restore or keeping the unrestored tooth as a fracture strength. Now, what's the downside for molars here? That's this. The prepared canal surface, the quality of preparation is inferior in the distal canal. And that's not surprising because the whole distal lingual canal wall remains unprepared. This is the typical micro-CT scan, red prepared, green unprepared. You can appreciate the pulp horns here and the small conservative axis, the pulp horn sticking out here. That is as small as it can be as far as your axis is concerned in their assessment. So the take-home message of this is, if you want to do a small size axis, and if you want to call it minimal invasive endodontics, you better do it just right, just to the point. Microscope use is, I think, essential. The ability to manipulate instruments so that you can remove tissue in these undercuts is essential. Otherwise, overall antimicrobial efficiency could suffer, and we certainly do not want that. So coming to that part, there are certain demands that we can place on an endodontic instrument. In the process of developing TruShape as it stands right now, we considered a variety of demands. Let me go through this, but before we do that, I want to highlight one other thing here when we talk about demands. Irrigation would seem to be improved in a large preparation. Harold Messer gave me this slide a number of years ago that has been printed in Pathways. MB1, MB2, maybe coronal 1/3 of the root canal system. Magnified MB2, you see here, pretty round preparation. You also see, this is 100 micron here, that we are about 250 or 300 micron on the towards the mesial wall, close to a perforation here. It's not overt perforation, but it's close. What you also appreciate is this zone here. We see the isthmus, the triangular structure that opens the isthmus to the canal, compacted full with hard tissue debris, dentin shavings containing bacteria, and packed densely into that area. In other words, it is very difficult to remove these dentin shavings. There's very few studies looking into dentin shavings. Several that the Zurich lab did had started this investigation years ago, and my colleagues there have now quantified these dentin shavings. Depending on the instrument type system, on the irrigation system, you leave varying degree of these debris particles behind. There's a recent study by Gustavo de Diaz's group that also looks at the isthmus. I don't particularly care about the isthmus. If you make a larger opening, you may be able to get irrigant into that scenario to some extent. But this doesn't have any direct or not much direct connections to the PDL. It's different apically. When you compact that amount of debris with bacteria apically in canal ramifications, you end up with areas where inflammation is supported by LPS and other components of bacteria in the interplay with the PDL. And that debris, you have a very hard time getting away if you can ever do that. So this is one of the key demands. Don't produce as much debris as you see here, but rather have these zones open for irrigant to get into that space. So when we start out with the demands, On that note, we have a couple of things that we have to add to that menu list. User safety efficiency. We want to keep an instrument that is effective, antimicrobially effective overall, but also doesn't fracture, doesn't create a canal preparation with significant preparation errors. All the literature on nickel titanium tells us that the significant benefit from nickel titanium lies in the fact that we do not have the gross error to the same extent that we have it in the stainless steel files, apical zipping, strip perforations, and things of that nature. So we don't want that. Plus, we don't want to have intracanal instrument fracture. Instrument fractures are an annoying thing. They're not necessarily significantly reducing outcomes, but my personal outcome is damaged if I have to declare to the patient, oh, an instrument fractured or separated in your root canal, and we have to deal with it somehow. So that's a starting point. I mean, we don't want to change anything. If anything, we want to get better there. The second point, as I mentioned before, we want to be as good as we can to optimize disinfection potential. When it comes down to what we have two types of contamination in the root canal system that we have difficulties with. Planktonic bacteria, burden, and so forth that's free floating in the canal is very easy to flush out. What is very problematic is biofilm that sits in canal spaces that we do not reach with conventional instruments. These biofilms need to be mechanically stimulated, detached, or at least broken up so that subsequent irrigation solution can remove the biofilm. And third, we have some bacteria deep in the dentinal tubules or in canal ramifications that can be sheltered, as I showed you just in the last slide, by our operational procedures. All these things we need to look at in order to optimize disinfection. And thirdly, we want to do this without making a big hole into the tooth. It doesn't make sense, and Erica Branson has used the word legacy technology to describe this, and I think he has a very valid point here. It doesn't make sense to adjust the tooth to our tools. We should adjust the tools to the tooth. So in order to retain structural strength and long-term function, we have to work in this direction. There's no doubt in my mind. And an example is classically straight line access that we have to prepare in order to allow our instruments to rotate and move freely, not being impeded by a coronal additional curve. That's really driven by the mechanics of the instruments that we have right now. So starting with that kind of small but significant menu list, we looked into how can this be done. The idea is good. The idea was not my idea, and I want to make this very clear. I was shown the early prototypes, and I was excited by it, and hopefully you'll get excited also by it. And we worked very carefully in getting these prototypes into a workable clinical solution, which is called TrueShape. It consists out of, at this moment, 4 key instruments and some additional tools or instruments that need to be used to develop the full potential of these instruments. What is so significant is a very substantial S-curve on the cutting portion of the instrument. It's a special alloy, more mountain-acidic than M-wire, and that has tip sizes of 20, 25, 30, and 40. We denote these instruments with a V to illustrate that the taper varies. The blank, the wire, has an apical taper of 0.6, but only in the apical 2 millimeters. After that, the taper regresses to permit a maximum fluted diameter of 0.8. The fact that this instrument has that strong S-curve allows it to spring back in between the largest possible side, that could be called an envelope of motion, and the smallest size that it has, which is the size of the blank, of the metal wire that is shaped into a rotary instrument. We call this a responsive envelope of motion. So in other words, this instrument is as big as it needs to be for a canal that is bigger than its nominal size, but can be compressed to a very small canal without over-preparing that root canal. Owing to the fact that it is narrower, much smaller in fact, in its maximum fluted diameter, higher up, the instrument has a very high fatigue resistance. The sizing, we feel, is appropriate for the typical caseload that an endodontist sees. Clearly, an anterior of a youngster is not ideally prepared with a 4D04. And we won't profess that 100% of all teeth can be prepared with this root canal system. But the vast majority of cases, I think, lend themselves, and we have seen this in our residency clinic where we have had TrueShape for quite a while now. The vast majority of the cases lend themselves very nicely to this array of root canal instrument sizes. And finally, because it's such an unusual instrument, and those of you who have used this instrument can vouch for that, we have a very specifically taught directions for use set in order to maximize the clinical potential for this instrument. This is a schematic drawing that includes all 4 instruments, and I just want to send your attention to this very significant S-curve that you can see here. As you can tell, just from the very tip, the instrument already sets off with a slight angle, so the actual taper here is not so much the taper of the blank, but the taper that the instrument is allowed to rotate freely or compressed. I think I have a graphic that gives you an idea how this will work itself out going forward, and I will show you that in a second. But I also want to make sure that you understand that the maximum fluted diameter is the same for all sizes. So the true fluted length for a 40 instrument is a bit shorter than it is for a size 20 instrument. Let's take a look at this video. John, can you switch to that video? That would be phenomenal. So this is a super slow motion video of a TrueShape instrument rotating in a transparent plastic tooth that you can see in 2 views here jointly. So let me start this here. And this is the mesiodistal view, and this is the buccolingual view, like the conventional radiograph. As we all know, the buccolingual dimension of the canal seen here is much bigger than the mesiodistal dimension. This seems to be a very slow rotation, and that is only because we're shooting this video with 1,000 frames per second. So the actual RPM is 300. What you can tell is because in this dimension the instrument is not restricted. It can swing from the far buccal to the far lingual wall. While in the dimension where it's restricted, it makes a much smaller envelope of motion. That is the key of this technique. The springiness that is built into the file allows it to respond to the canal cross-section. Okay, let's go back to the slides. I think this is very impressive. It makes a whole lot of sense. So when we saw that, we said, oh, there is something to that. And we have now tried this in a variety of in vitro settings, and I will come back to that in a bit. But we address this in a couple of different ways. The first question is, according to the demands that I laid out before, will this work? If I give this to a clinician, will that actually perform as advertised? Well, usage is as follows. We want to have a consistent use. So what we did, we sent this instrument to a variety of user groups, and maybe several of you have been part of those groups. And we asked, did it work for you? Did you need a training phase? What was the feedback? How do you feel about the usage criteria? And we got pretty good feedback, and some said it's very easy to learn, some others had a bit more of a problem. But as long as the directions for use are followed closely, we had good success with that. The things that are important is 300 RPM. 300 RPM has in vitro tests have told us that this is a good rotational speed. 300 gram centimeters or 3 Newton centimeters of torque, and a gentle in and out sweeping movement. A pecking movement is not appropriate for this instrument. The way this smaller fluted diameter functions is best with a light touch. For those of you used to pecking motion or maybe a pro-taper motion, which is a little bit more of a heavy-handed motion, that requires just a slight bit of retraining. Some other instruments are lending themselves equally to a gentler, light-handed motion, and those users have an easier time adjusting to TrueShape. We think single patient use is good, in this case, in general anyway, in this case we prefer this as a single patient use instrument. And the reason for that is the springiness, the S-curve, is being used up to some extent preparing in narrow molar canals. So you lose the ability of the instrument to adapt if we use it in more than one molar tooth. So I wouldn't recommend that. These are pre-sterilized instruments, should be used in one patient only. I'll present to you some data on torsional resistance and on fatigue resistance, and that's important in order to avoid fracture. Here's the data for fracture resistance in terms of torsional resistance. The test is very simple. That's the standard isonorm or 8820 number 28 test, where the instrument is clamped at D3. When I compare what we see for TrueShape with the well-established rotary instrument, in this case ProTaper Next, we see that we have very similar values for nominally similar tip sizes. Well, that's owed to the fact that the apical taper is 0.6 and 0.5, so the difference at D3 is very minimal in cross-sectional diameter. In other words, if you have a functional glide path, it is very unlikely that this instrument fractures. It may feel a little different, but it's very sturdy, sufficiently torsionally resistant to not fracture. The other situation where an instrument can fracture is fatigue. But before we come to that, let's compare, and this is a slide that I used my special torque machine to develop. If we look at torque in purple here and force, apically directed force in blue, we find that the torque that the instrument is subjected to is almost always below 3 Newton centimeters or 300 grams centimeters. So when we go back one slide here, 3 Newton centimeters is way up here. So the tip, in theory, could fracture if we do not have a good glide path. One of the directions for use would therefore incorporate a glide path preparation with the path file size 13 and size 16, the first two path files. Second, a motor setting of 3 Newton centimeters is in almost all cases in the lab appropriate, and in clinical reality I was well below that. So that's how we determine these numbers. There's a whole lot of in vitro testing going into that. I promised you fatigue numbers, here they are. In terms of rotation to fatigue failure, we are well above, almost double for all cases except for the 40 here, compared to ProTaper Next, which is a well-established and excellently working instrument. So neither torsional load nor fatigue will fracture this instrument. We have a good usage safety. Why is that? We have a somewhat martensitic instrument, and these are DSC curves. I don't want to go into too much detail here. That tell us that somewhere in the region between room temperature and mouth temperature, the martensitic conversion occurs, and this needs to be set that way in order to afford the instrument sufficient springiness when it is in the patient's mouth. A couple of ongoing projects here, and one of the discussions is certainly cutting efficiency. We use an Orifice modifier in this set. That's a blue alloy instrument. And in the last year, I had the opportunity to test quite a few of these instruments, and I had an established cutting efficiency protocol. And we can use the benefits of the softer alloys. And actually, we do retain a good cutting efficiency. Another experiment that we're doing is associated with the question of root fractures or microfractures. We haven't really published anything on TrueShape and the role of microfractures. We do not see in early stages of this study any predisposition of this instrument to create microcracks. I think this problem is overstated anyway in the literature at this moment. I'm pretty sure we will be in the same situation that we were when we had ultrasonic retrograde preparation, and many of you will remember that initially there was concern about cracks, apical cracks, but better experimental designs eliminated these concerns for the most part. And finally, retreatment. This instrument at this moment is not considered the primary instrument to remove gutta percha in retreatment. It can prepare the canal after a glide path has been re-established. Let's come a little bit to the practical use. So we have mentioned this Orifice Modifier, which is an important tool due to the fact that the true-shape rotary is not ideal to drill its own access. We want to be as gentle as we can and want to create a receptacle with an instrument that is a size 20 at the tip and has a maximum fluted diameter that's just below the 0.8 of the true shape itself. So with this, that is built in a short set here, we achieve exactly that goal. We can prepare this receptacle without over-preparing and directing the shape of that receptacle, let's say in an MB2 of a maxillary second molar, would be hard with the true shape. That's something that we decided that we needed in the pre-trials. I talked about cutting efficiency. The data is out. We know that in lateral cutting, these multi-synthetic files do cut, and I show you some data here. This is HiFlex, which is a very multi-synthetic instrument. BioRace, Profile, ProTaper cut actually less than a soft instrument held against this dentin substrate here with half of the force. So that tells me that a very gentle hand movement, with not a whole lot of pressure, does it with these new types of instruments. And we have done similar trials for blue alloy and gold alloy. I talked about the cracks. This is Adorno's work. You don't really see anything of major substance here. After some instrumentation, he appreciates this crack here. We do not know what state these teeth were in before they were extracted. We do not know what extraction forces were used. We do not know how the teeth were stored. As I said, we don't know if this is valid or not. Let's tackle this question. We have said usage safety is reasonable. Will it be better? Will it help in disinfection? We do not have very solid clinical data, obviously, because it's too young. What we do have is this study that I just got out in the Journal of Endodontics in the September issue. Instrumentation, circular preparation, here with Vortex as a comparison instrument, here with True Shape, is at least as good. This is coronal third, middle third, apical third, at least as good with True Shape as it is with the conventional rotary, while the conventional rotary sacrifices 36% more dentin in the process. So that is something where we can hang our hat on. How much that aids in disinfection is not seen directly in this study, but what we can say is that True Shape provided conservation of dentin by limiting dentin removal in the absence of substantial canal transportation. No instrument that I have seen up to this point has zero canal transportation. This has the lowest amount of canal transportation from what I have seen so far. But we do have another study here. This is Franklin Tay's group, where, and this published in the Journal of Dentistry earlier this year, very similar setup in single-rooted teeth, oval canal cross-sections. And the conclusion that they end up with is, they said True Shape files removed significantly more canal wall bacteria than twisted files, that was their control group, when used without an antibacterial irrigant. The latter is required to decontaminate dentinal tubules, and I would add is also required to aid disinfection in canal ramifications that are not accessed by any preparation. What I showed you earlier, remember the isthmus region where an instrument is not going to significantly remove any dentin. Well, that's an early study. We're doing more antimicrobial efficiency studies going on in the future, and we need confirmation for this. But clearly it's pointing in the right direction. When I say more studies, this is one thing that I'm thinking of. When you appreciate a particle velocimetry, this is a glass or plastic tooth, in this case with Jim Bacal's plastic finishing file, rotating at 600 RPM, creates streaming effects in between the file, which is in the middle here, and the radicular wall. We do not know exactly what the amount of shear forces is that develops in here or develops in here. Neither do we know the amount of shear forces needed to break up a biofilm, but I can guarantee you that a file that is closer to the canal wall, remember the glass or plastic tooth when the file rotated, will develop a specific fluid film here that can help us, and here, that can help us break up and potentially remove biofilm. More work needs to be done, but that's an exciting situation right now. We've just a paper that addresses this, so I've managed to convince John Koch to work on particle velocimetry. We will see where this goes. Well, the ultimate question is, we can develop whatever we want. If we focus on dentin preservation, the question has to be, does bulk dentin really matter? My answer is yes. Why do you think that? Well, we have some convincing in vitro studies, and we have some good clinical outcome data, and I'll share that with you just now. This is a paper out of Serbia, International Endodontic Journal, just came out, was in press 2014. What they did here is, and I don't want to go into finite element analysis in too much detail, what they did here is a pretty sophisticated setup where they can validate by subjecting a mirror image tooth to fracture tests in an instrument machine, in an actual fracture machine. They can validate what they see in silico, in the computer. The summation of access cavity and a DO preparation, this is in premolars, resulted in 63% reduced load needed to fracture. A bonded composite did not rescue fracture resistance. This is important because there's two components to that. The access cavity, remember what I shared with you early on, having a smaller access cavity, if at all possible, is a big component. And second, the canal preparation itself adds another 15% or so to the loss in fracture resistance. And this is specifically when you look at the data that they generate here. This is their workflow. One tooth tested in the in vitro, in the testing machine, the instrument machine, where they get a stress strain diagram, and then they have all what they can do in the computer that they can validate with the ultimate fracture numbers that they have in a test setup. These are two teeth of the same patient, not exactly identical, of course, but the same second premolars of this one patient. So when you look at the data, this is from our lab, we're doing the same things here. It matters greatly where the dentin is removed, because the interplay between periodontal ligament that we model here and the bony support, this is the little block that we model. So the interplay between the periodontal support, red here, bone, and the dentin is where the forces are changing, right here, right here. All what happens here is where the load is applied. Don't worry about that. But what we do see is different types of situations along the route in reference to what the periodontal support is. And this is all done at physiologic forces with reference to fatigue type loading, not to fracture, but to in response to what normal and parafunctional forces are. So we do have a sense, this again is the so-called von Mises stress profiles, average von Mises stresses and maximum von Mises stresses. And this is with restoration. So we've spent quite an amount of time in looking at teeth that have a natural anatomy and are prepared in different ways, as we can see up here, in comparing where exactly dentin is removed. What is the difference using an orifice shaper that is much larger than, for instance, the orifice modifier here? What's the difference in having an 0.6 continuous tapered instrument versus an instrument that has regressive taper? It is really for a person that has healthy periodontal support here in this pericervical zone where the entry into the canal is, where the level of the osseous support is, where the most drastic changes occur. I think that's worthwhile remembering. Obviously, we don't have any clinical data at this moment, as I have said before. What we do have is we have data from the literature, and the best data that I'm aware of is a systematic review by Kish Gudavival's group, Paula Eng. And in this case, we have a very sophisticated, I don't know, this is almost 20 pages, sophisticated setup that looks at a variety of things in their assessment. This is 2010, and a certain type of instrument has been developed at that point. In that assessment, the preparation factors comparing one 06 instrument to another 06 instrument didn't matter. We're different now. When you ask what they conclude, the factors beneficial for survival was crown placement, full set of proximal contact, not serving as abutment, and the tooth type. But more specifically, what they say is this: amongst the many reasons cited for extraction of root-treated teeth, the most common reported were large caries lesion, unrestorable tooth, followed by tooth fracture, periodontal disease, and last of all, endodontically related diseases. Isn't that exactly the same what Thomas Quist concluded earlier this year? And more specifically, the restorative factors should ideally include the amount and distribution of remaining tooth structure, the amount of distribution of occlusal loading that we cannot control really on the tooth and the function, and the type of final restoration. So we as endodontists can really control the best this point here, the amount and distribution of remaining tooth structure. Yes, you will say, or some of you may say, what if the patient comes already in with a large restoration? I would submit that it's even more important at that moment to preserve structure at the coronal interface, where we may be tempted to do a large or substantially sized coronal flaring exercise. So I think we are well served in getting a good sense of where the forces are at work and what type of forces we have. And therefore, I would say the clinical impact of minimizing structural changes could be significant. Whenever conducive, a reduced access is a good thing. And I'm not talking about super radical accesses here with tiny keyholes or anything like that. We have to marry these concepts with good, sound clinical principles. We want to see and want to be able to see if there's a fracture underneath, right? And so we got to work with adjusted coronal flaring. I don't think we want to give up using good judgment. Structural changes could also be at the micro level. Crack nucleation is still a possibility. We have to keep working on this. Aggressive shaping and aggressive obturation procedures may lead to substrate changes, to cracks. We don't know which type of instrumentation or obturation is more prone to that. But we want to add to the fact that dentin is avoiding crack propagation by nature. It is only as good as it could be. In other words, just usage, chewing on a tooth, perhaps will create some crack initiation. Irrigation is another factor here. Aggressive demineralization or aggressive removal of collagen could also lead to some changes here that alter dentin behavior in an unfavorable way. Altogether, clinical efficiency should be increased. Disinfection is important. The instrument should not break. The future of shaping is now, in my hands anyway, and specifically in the hands of our residents. These are a couple of TrueShape cases that they have created. Different aged patients. These are older patient. This is a younger patient, as you can tell by the second molar, maybe 16 years of age or 15 years of age. Another tooth here. And in substance, in the apical size, there doesn't need to be a big difference. In fact, my go-to apical size hasn't really changed. It's still a size 25 or a size 30 with an appropriate taper. And these sizes we provide. It could be a size 40. For instance, in this case here, the apical size is a size 40 in all canals. I think this is all what I wanted to tell you, except we have a couple of other cases, John, that I know we have prepared that I wanted to share, because it's not only us that can do these. We have a core group of users that are discussing with us what they have been able to accomplish. And I just got a beautiful case sent to me today that is phenomenal. So I'm convinced that this is not necessarily in my hands or my residents' hands, a very innovative and very effective technique that can master endodontics going forward, because we need to concentrate on the goal that we have, keeping the teeth for our patients functional over the longest possible time frame. So I think what we can do, we can just take a quick look at these cases here, just for you to familiarize yourself with that. This is a straightforward situation by Dr. Rubicki in Michigan. I don't know if you are actually on the phone or on the webinar yourself. I have not met you, so this was sent to me. I don't know the specific details, but I can appreciate the double curvature here and the overall anatomy. If you notice that he prepared these distal canals as if there are two canals. One of the take-home messages for me personally, looking at these micro-CT scans, is that we underestimated the complexity of the distal canal in a lower molar. From anatomical studies, we would say, well, there's maybe 30% or 40% chance for a first molar to have two canals. I would say in my micro-CT data pool, almost every distal canal has either a significantly large apical ramification or two overt canals starting from the apical third. Another canal here that luckily does not have two canals, this is Jeff Coyle, Vancouver, Canada, and I was just talking to him about this particular case the other day, and so he shared with me that the apical size that he put into this significantly curved distal root is a size 25 true shape. So this is good, and actually I saw an even tighter curve as I mentioned earlier today. So 25s both in the distal and in the mesial canal after the sequence that we recommend: path file 13 and 16, true shape size 20, true shape size 25 to length. Very nice case. Instrument breakage is not a topic. I think he has fractured in the, I don't know how many cases he has done. He has fractured a total of one true shape. Let's go and take a look at the next one, if you can, John. So what we see here, let me take a look at this one. Dr. Stout, San Diego. This is another case that is a retreatment case, and that is an interesting application for true shape, because the assumption would be that as soon as you have being able to bring a small file, like a K file size 10 to length, the true shape instrument should engage the wall better to remove obturation material. We are running a study at this very moment, and I haven't seen the data come back, but I hope I can report on that soon. He certainly gets a good clinical result in this case that is convincing to me. Let's take one more look at the last case by Dr. Cancelier, also from Southern California. Let's switch to that one here. And I know that Peter is always interested in doing the new things and doing things in an innovative way. And he was working this four-canaled upper second molar with substantial curvature to a good enough apical size that he has a good disinfection protocol at work here. Not a problem for this instrument. The curvature is not super acute, but still is a 90-degree curvature both in the MB1 and the MB2. These are just one collection of quite a few other cases that we have in our database. So that's really all what I wanted to share from my side, and I don't want to overburden your time commitment. So let's go right into a couple of questions here. And please type ahead, and I will just go about this in the following way.
If I could interrupt just 1 second, Dr. Peters, you are able to see the questions then, okay, in the Q&A pod?
Me? Yeah, I see a couple of questions.
As you click on each one? Perfect, yeah. So just want to make sure, and if you don't mind, I'm just going to bring something also on screen, and this would be especially for those who have logged in, registered individually, not so much the ones in our rooms, but that is, it would do me a huge favor, those of you that are interested in CE credit, for tonight. In addition to me seeing how long you were registered and logged in tonight, I've brought on screen something that you can click on and then download, which is simply an evaluation form of tonight's event. And so receiving that back, there's a couple emails and faxes on there. If you could do that, if you're interested in CE credit, send them back to me, and I'll marry that with tonight's registration and roster, and I'll be able to award CE credit to those people. The reps, I believe, have everything they need for those who came and attended a room in order to just send in a roster sheet and send in CE credit. So I'm going to leave that on screen just while you answer these questions until I need to move it for anything you need to illustrate. And I'll just make sure, again, if you can repeat the questions for sure, because nobody can see those. So
most certainly. And I mean, while you have the microphone, is there anything else from your side that I need to do or not to do?
No, no, you're doing great. And you're right, we are very timely now, so I don't want to take up any more time. But yes, just click on each question if you need to explode them to see the full question and read them out loud. Great.
Okay, so there's question number one. TrueShape file 25 millimeter is 25 from the tip to where it inserts into the shaft. Yeah. If the file's curves are compressed, inserted into a narrow canal, how long does the file become? Compressing the curves should lengthen the file. Yes, that's correct. Would this interfere with maintaining working length measurements? Could the canal be over-instrumented? A very reasonable question. We approach this, we anticipated this question, we approach this in two different ways. You can use software to manipulate a file that is stamped into the S-curve, and you can also compress an actual file in a physical small canal. These measurements have shown that the maximum enlargement or lengthening that a file will undergo is 0.2 millimeters. 0.2 millimeters is not clinically relevant, and I don't want to oversimplify this question here. The accuracy that we can measure this in clinical reality is 0.5, and if we are super concerned about this, and we should, and I think that's very reasonable, we should reestablish working length with just changing the stopper appropriately when we have the suspicion that the file is extended. We would not necessarily see minute changes in file length. We made a little guide and tried to measure clinically the file curvature so that we can vouch for the fact that the file has retained its exact springiness. In the amount of accuracy, even using the microscope, we didn't really see any changes. So in other words, while I think this is an appropriate concern, I don't think it changes clinically what we do. You recall that you may recall that the self-adjusting file is a system that is transaxial, going in and out. And the in and out movement of the self-adjusting file was plus and minus 0.2 millimeters for a total of in and out movement of 0.4. Even that is borderline clinically relevant, but this is double as much as we have the movement for this file in maximum stretch, which is not very frequently occurring in the first place. I think this is that question, so let me see. Yeah, how effective is the file for retreatment removing gutta percha? When I tried to remove gutta percha that has set for some time, it is hard for the file to dig its own way. This is not the way to use this instrument. You got to have a pilot canal, maybe using a heat source or some kind of a small instrument to have a coronal receptacle, use a drop of solvent, and create a path with a size 10K file. Once you have a path to working length, or even shorter than working length, you can use the instrument only to the depth that the K file went. It's not meant to dig in with its tip. The torsional resistance on the length of the file is not sufficient for that. The tip is torsional resistant, but the length of the file when engaging a whole amount of gutta percha is not going to be sufficient, so we will plastically deform this instrument. It works very well once a path is established with a K file or things of that nature. As soon as we have that, gutta percha is removed very efficiently, but I cannot show you any data. It's just a visual that I have from the study, but I need numbers to give you a clearer picture here. We hope that we see that later this year. Okay, there are many endodontists here today that already believe in dentinal preservation. They're using systems like BioRace. How and why would they make the change to TrueShape? That's an interesting question. BioRace is an interesting instrument, but because of the way it's tapered, I would doubt that you can achieve similar coronal shapes than you achieve here. I'm very familiar with what FKG does in Switzerland, and so I have the new instrument that you may or may have not seen, which is called the XP-Endo, Expando, which is an adjunct to the BioRace system that uses actually a very similar process that we have here, with the only difference that this is an additional adjunct, strong S-curve, and tries to reach some additional spaces. The BioRace in itself does what any rotary instrument can do. It stays in the center of the canal. Some results of research papers say it does it well, and some others say it does not do it well. It's certainly not a minimal invasive instrument. When you look at what is out there, there's another minimal invasive instrument, or is billed as minimal invasive, that's V-taper. When you look this up in the literature, there's very little data. The only paper that I could find is that V-taper doesn't really prepare any different than a sequence of K files. So it comes down to looking at it from a variety of angles. Why would they make the change to TrueShape? Well, the individuals have to decide that. I would try it. Like I have tried everything. You know, I don't tell you any secrets by saying that I started out completely differently. My first instrument in the late 90s was Lightspeed. It's a completely different paradigm, and I bought into that paradigm. I said, oh, well, this looks good, that works very well. But I did the clinical studies also on that, and it didn't seem to work any better than a small preparation clinically. You know, I'm in a unique situation. I've been able to do benchtop studies, quite a few of them, but also have been able to do actual clinical outcome studies. Let's go to the next question here. Does the use of a PIPS laser protocol for debris biofilm removal have merit to address those intracanal areas not instrumental in increasingly conservative preparations? That's a very good question. Some type of protocol will emerge that has merit. I think PIPS, and I have, as the person who asked that question may know, I've done some work with PIPS. PIPS is a step forward. It's not completely eliminating bacteria. We haven't seen any system that can eliminate bacteria and can eliminate all debris. Some type of irrigant activation system, I think, is mandatory. At this moment, in my clinic, we are still using ultrasonic irrigation, or agitation, I should say. We have done some experimental PIPS work, but I still haven't received any PIPS equipment for the clinic. It has merits, and we got to look into this and keep searching for a better toolkit. There are things on the horizon that not only address the way the irrigation solution is moved, but also the irrigation solution itself. I wish we had everything laid out, but for right now, we have the instrumentation system, and we should say also we have a suitable obturation system. So maybe we come back to that. And you got to also, I want to add one thing to that really quickly here. The conservative preparation in this incarnation of what we have for TrueShape refers more to the coronal aspect than to the actual apical aspect. The apical aspect you can still bring to a size 25 effective, maybe 06 or 07 taper, or 30 06 taper. So that is not any different with a much smaller coronal dimension than what we had before. So we are not losing any apical irrigation ability here. In the study referencing the reduced bacterial load for the TrueShape file, yeah, excellent question. In the study referencing the reduced bacterial load for the TrueShape file, how was the bacterial load level measured? This is Franklin Tay's group. They're pretty well set up in Augusta, Georgia, but this was a traditional paper point sample study. They had a biofilm established, and they tried to sample this biofilm with a paper point technique. There's certainly more sophisticated ways of testing this, and I'm inviting everybody who is interested in collaborating on a study like that, or just trying it on their own, to take a look. We have a couple of things here, but I would prefer the more completely independent studies we can have. There is no established biofilm model right now, and maybe we find one. This question is the following. I have been using the 1-2-3 stroke technique described by Dr. Bruder. Are you advising the same? George Bruder and I wrote the directions for use together. So if I'm sure that he is describing it in the same way that we came up together. So I would say it maybe not as worded exactly the same way he does it here, but I think it's very reasonable. So we don't want to aggressively work the file to length. What he means by that is we go in sequence a little bit deeper. We do not dwell at any given point in the depth of the canal, and we remove the instrument to wipe it clean with a moistened gauze. The idea being that adherent debris should be removed, and it could be pulp remnants, it could be biofilm remnants, it could be dentin particles. So taking the time, being gentle, with longer strokes, 2 to 5 millimeter strokes, not aggressively pecking the tip of the instrument into the canal. That's probably what we both say. And by the way, any of you who feel like I haven't addressed the questions appropriately, by all means, type in another set of questions. And I have plenty more on the list. I see that. But if you, I want to also say, and John, you can also chime in. If anyone wants to email me either privately or wants to email Tulsa and then they forward it to me, I'm very happy to answer questions. I'm excited as anybody about this technique. And, you know, to be honest with you, never been willing to put my name on a product. But this is different because I think we can make real progress with this. Question from Tulsa. What's the irrigation protocol being recommended? Our irrigation protocol is not definitively set as far as the chemistry is concerned. A good protocol would be sodium hypochlorite as a reservoir in the access cavity during canal preparation with the rotary. That is, applying both to the path file and to the TrueShape instrument itself. After sodium hypochlorite has been used during the instrumentation itself, smear layer removal agent. And of course, one of the smear layer removal agents is Qmix. Another smear layer removal agent would be EDTA. The classic protocol would call for an additional sodium hypochlorite irrigation after the EDTA. You can do that, but then you have to be mindful of over etching and over removal of organic substrate with the second sodium hypochlorite protocol. Active or agitation should be provided both for sodium hypochlorite in the final stage or in the previous stage before EDTA, and certainly for the EDTA too. If you use Qmix, you only have to have one additional chemistry. So both irrigation protocols are possible. You don't have to buy Qmix, but certainly it has its benefits. Qmix has no good clinical data, but pretty solid in vitro studies. Next question. There are many endos here with me that already believe in dental preservation. Great. They are using HyFlex and Mounce files. How would they make the change to TrueShape? Well, it applies pretty similar to BioErase. You can hybridize many different things. I'm familiar with HyFlex. I'm one of the few people that have actually published on HyFlex, which is an interesting instrument because it has, in fact, as the name would suggest, a very high flexibility. Having said that, HyFlex has a continuous 04 and 06 taper. So it's not an ideal minimal invasive instrument. How can they change? Try it out, understand the benefit of the mechanics, and take a good look if the theoretical benefits that you would see with the alternative technique that you're using would apply also to TrueShape. I'm not selling you anything. I mean, this is not the topic for today. What I'm trying to give you is my perspective on why this is preferable. I would lie to you if I say our residents are using TrueShape for every single case. I think that's not appropriate for me as a program director, by the way. I think they need to try out everything, and they have to come up with something that they are comfortable with. I can show you very nice Vortex Blue cases or very nice cases done with BioErase or some other instruments that our residents have done. Certainly not that I'm forcing them to do anything specifically. Okay, let's take a look at this question here. And well, Oh, I'm sorry, I clicked on the wrong thing here. What are the dimensions of the orifice modifier? Okay, that's an excellent question. The orifice modifier inherently is an apical size 2008 taper, but it has a very short working portion so that the maximum fluted diameter is a 0.7 and a bit. So the maximum fluted diameter is smaller than the true shape size, and it has a very short cutting surface. So it is ideal, in my hands anyway, to work in a restricted space. I'm thinking of an 90-year-old lady, and we're working on MB2 of an upper second molar, right? And so then I want to make sure that I can angle this instrument, see it under the microscope, and can just make that additional movement to afford a receptacle. Some studies indicate that the volume of irrigation is one of the most important factors. Don't you think dentin preservation will affect this? That's an interesting question, and my short answer to that is no. Let me give you a longer answer. When you think of irrigation, the volume of irrigant that you can bring into a canal at any given time is the size of the root canal system. The size of the root canal system is about 10 to maybe 50 in a very large canal cubic millimeters. That's 1/100th to 1/20th of 1 milliliter. The amount of volume that you can actually bring into the canal is minute. It's not so much that, it's the exchange of this volume, it's the streaming activity that brings the amount of sodium hypochlorite that can actually have space in the apical portion of the canal. So when you think of, I administered 10 milliliters or I administered 5 milliliters, an absolute minute fraction of that is going apically. The amount of exchange has to do with the amount of streaming you can have. And that has so many factors that go into that. The needle type, the position of the needle, the type of force that you put onto the plunger, and so forth. Dentin preservation will only interfere with this if it impeded the placement of current legacy technology irrigation needles. Another question, don't you think that such dental preservation will affect the obturation? Here my answer is yes, of course it will. So we developed gutta percha that is appropriate for this. And I didn't have time to show you this setup. This is gutta percha that has a shape that is appropriate for the smallest possible size that true shape will generate. It also has a formulation that allows the heat to be transducted into the gutta percha deeper than conventional gutta percha. Again, the same applies. We do not want to adjust the tooth, the canal shape, to our toolkit. We want to adjust the toolkit to what the tooth can give us. And the cases that my residents did were done with this true shape gutta percha. What makes this instrument single use? I didn't include this paper into the presentation because it just came out a couple of weeks ago, actually, maybe 3 weeks ago. Proceedings of the National Academy of Sciences, Stan Prusen and others, where they show that prion protein, which we have never really considered, prion protein may actually be involved in the development of Alzheimer's and and Parkinson's and other new degenerative diseases. So when you keep that in mind, I would be very careful not reusing instruments. Recall, prion protein cannot be effectively removed from any nickel titanium instruments. Stainless steel, a little better. Nickel titanium, very poorly. But that's a side note right now, because this is the first paper looking into this. What is important for single use here is that true shape works because of the S-curve retained and the springiness that is in the S-curve. Overuse, you lose some of that springiness. So you lose the benefits of that. It's still workable, but it works as any other triangular cross-section rotary instrument. So single use is something that I would definitely advocate. Let me read this. It was during the presentation, he mentioned excess debris in the canal during traditional rotary. Yes, that is exactly what I'm saying. So when you look at studies, for instance, Spongberg has these studies with the Korean group in the early 2000s, the amount of particulate debris, smear layer and other things varies significantly from the instrument type to from one instrument type to another. A profile with a radial landed cross-sectional geometry will rub a thick smear layer into dentinal tubules and accessory anatomy, leading to smear layer plugs that are deep in dentinal tubules, as opposed to a triangular cross-section that shaves some more particulate debris. When we saw that, we looked at the micro-CT data, and the micro-CT data unequivocally showed that debris is retained. We create debris. We gotta be very careful about this. Debris is not in the canal before we prepare it. As soon as we prepare it, we create this debris. We think of debris of bacteria and biofilms. That's not what I'm talking about here. Debris is dentinal shavings. Dentinal shavings will then incorporate bacteria, and that's going to be packed into the spaces where the instrument doesn't go. That's the simple thing here. Okay, leaving the file in the canal too long would cause the debris. Well, that's certainly a potential reason for that, but that's not the only reason. It's handling. Taking the file out in this 1, 2, 3 step, as we talked about, is a good thing, but also having a file that removes debris coronally rather than pushing it forward plays a role. The cutting plays a role. The amount of debris that you create, in other words, the size of opening you make, play a role. There's a variety of different things that go into this. Leaving the file too long is detrimental for another reason, and the reason is straightening, canal transportation. For any triangular cross-section, you will have that. This is not particular a problem for TrueShape because the restoring forces are small due to the flexibility and the small caliber of the file. But it's in principle still something that we are concerned about. Getting to length, don't park the instrument, take it out. Doesn't do any good to wait. Should the call for minimal invasive endodontics be more based on coronal conserving with less use of orifice flaring? Yeah, I think that's a very reasonable consideration. I think this is something that I would certainly subscribe to. This is a concerted effort on our side and also on the restorative dentist side. Again, we are working in a legacy technology environment. Can we achieve complete disinfection with an apical size 10? I would say at this moment, with the technology that we have at our disposal, not even close. Can we achieve a complete disinfection? From a microbiological standpoint, disinfection would require reduction of bacterial load by 3 orders of magnitude, 99.9% bacterial removal. That is the condition for disinfection. Oftentimes, we do not achieve that. We gotta get the hierarchy of outcomes right. We will have to live with some bacteria. There's just no other way, short of extracting the tooth or putting the patient in a gamma ray sterilizer. So as long as we suppress the bacteria to a level that is appropriate for what we call healing right now, I think we are doing a good job if the patient is still having the tooth for a lifetime. Legacy technology will dictate an apical size at this moment. That's the way I look at it right now. As you may know, there is a sonendo that tells us, and I've been very interested in this technology, that tells us that minimal instrumentation or maybe no instrumentation is a possibility. They have some interesting data, and I hear that new studies are coming out. I have yet to see that a non-instrumentation technology, recall that they require a size 15 or 4 preparation at the moment, a non-instrumental technology is consistently removing all bacteria or a sufficient amount of bacteria so that we can call it disinfection. I just don't see this at the moment. This question extends it a little bit. I think the call for minimal invasive endodontics should be set aside for all flaring devices, similar to what Sergey Cutler said, but beyond gates and more focused on all orifice flaring devices. Well, I cannot disagree with that. I think that's very reasonable. Many schools of thought are using an SX as an orifice opener, which is a phenomenal tool if you bring it just 2 millimeters into the coronal portion of the canal. But as soon as you start sinking this deep in, then you end up with a preparation that you do not want. But this is only necessary because our toolkit requires that. A continuously tapered or large tapered instrument gets such a big cross-sectional diameter, maybe at D10 or D12, that the chances for overt fracture or canal preparation that's erroneous is very high. So this is in the technology that we have. Good questions. You guys are awake, and I'm using all my power here. What about apical negative pressure irrigation? The Endovac is an interesting tool, but the Endovac requires an apical size 3504. So only if you have that size can you use that efficiently. We do not have that size in many true shape preparations, so we do not recommend that on a standard basis. Can that be used? Let's say if you have a true shape 40 to length, yeah, you can use that, but we don't recommend it at this moment. Interesting. So let me move this down. Does the chlorine content of sodium hypochlorite adversely affect the strength properties of metal used in true shape as it does with traditional nickel titanium files, significantly weakened by sodium hypochlorite? We have not tested that specifically, but I have looked at this many times, and I have actually published on this very thing. Under normal conditions, exposure time and the like, a regular nickel titanium file would not be adversely affected by sodium hypochlorite. When we do see corrosion and some other significantly negative events, that is typically when you have the file completely, including the shank portion, the handle portion, immersed in sodium hypochlorite. I had one study, and there's also a study out of Peter Parashos's School of Thought in Melbourne, Australia. For cleaning purposes, a file is immersed in sodium hypochlorite for an extended period of time. You have significant corrosion and disintegration of the instruments. If it is body temperature or room temperature, and it's only the cutting portion of the file that's immersed in sodium hypochlorite, there shouldn't be any real significant deterioration of the instrument. The nickel titanium alloy that is being used here is standard nickel titanium. It will be affected by these things as much as any other instrument. There's no change. It's not any different alloy. What is different is the sequence of heat treatment, because you have a machine process here that makes the triangular blank in the way that the flutes are designed, and then you have an additional process where the S shape is formed into the file, and additional heat treatment is required for that. So I'm not concerned about any of these things as far as clinical usage time is looked at, and certainly not when single patient use is advocated. Okay, is there a particular type of sealer that you advocate? That's an excellent question. I would love to have a sealer that is in some way conducive to healing. Right now, we don't even know what this would look like. Personally, in my program here, we use AH Plus as the sealer. Is there a particular true shape sealer at this moment? There isn't. We're still working on some sealer products that could help here, but right now there's no specific sealer that I would advocate. I have seen cases that were done with bioceramic sealer. It can certainly be done. I don't think we have a whole lot of data right now to make an immediate switch to bioceramics type sealer. Who knows? The evidence is only emerging right now. So the answer to this question, I guess, is no. There's no particular sealer at this moment. I think this is all I have on my list here. You're very brave, you guys. Is there any other question that you want to bring to my attention? And by the way, I mean, if you go back to my last slide here, John, if you can, and get these nice cases out of the way, there's my email address, and by all means, email me, and I'm happy to respond. This is my school email address down here, and I'm certainly not every time available, but as soon as I see this, I'm happy to respond. So John, help me if I'm seeing this. I think this is all the questions because it's in chronological order, so I don't see any new questions down there. But I think I want to.
That's right. Yeah, I think we should be in good shape. I think I'm going to bring something else on screen, which is just one more time for those that want to do the evaluation form and send that in for CE credit. And like I said, I think most of the rooms already have the forms that they need to take care of those that attended the room. So,
Great.
no, you know, what a phenomenal job. Thank you for spending this much time, and thank you for all of our attendees. It looks like we really still have a pretty full house. So I appreciate everyone attending, and I hope you've had great information sent to you, and then also great discussions at your various rooms and everything. And Dr. Peters has offered his email address, and I know you can reach me from the various communications you had to attend this event, or your reps anytime with any further questions. So, no, I would say, and I do appreciate there's been a lot of people sending in selfies. I wish I could have brought those up for everyone to see, but it looks like they're all having a pretty good time in addition to learning some good information. So I will leave the room open. And Dr. Peters, I don't know if you want to just stay on maybe for a couple minutes in case they get a couple last-second questions that might pop up at the bottom.
There are. So I don't want to cut this short, but I will answer these questions. But I want to make sure that I tell you that, you know, I have a 6 o'clock telephone conference for a book with Dr. Torabinejad that I got to take a look at. But I'll let them wait a little bit because this is more important for me. How about the metal? Not quite sure how to answer that question. This is nickel titanium. That is heat treated, and so I've shown you the DSC curves. This is somewhat martensitic, not as martensitic as a pliable high flex type alloy. So that's all I can tell you about the metal. There is a patent if you're interested in that. There's a patent that details the heat treatment process as far as the forming step, and beyond that, I really don't want to reveal any company secrets or anything like that. Thank you. I appreciate that. I thank you all guys for looking in. This is phenomenal. Another thank you. That's great. You know, my life is good, not only because TrueShape, but life is good, and I appreciate all your interest. I think I have to sign off now, and I have 2 more tasks here before I get to the other phone call. But I'm working on some obturation material. Oh, that's great here, all these selfies. If I have some more to say. So for right now, I'll sign off. Thank you very much again, and thank you, John, for being patient with me. Bye-bye. All righty.
No problem. Thank you very much, sir. And yeah, thank you. And folks, I will just keep the room open just in case maybe you want a backdrop or something. And again, the eval form is there for those that logged in individually and might want the CE credit. Your reps can take care of you if you're in a room. And I will go ahead and mute my phone and actually kill the audio and let you get on with your evenings. But I thought you might enjoy seeing some of the rooms we had around the country and stuff. Look like some people really know how to do these kind of things right. So thanks very much to Dr. Peters for helping us with this information, and also to all of you for attending. We appreciate and look forward to having you in another one in the future. Good evening.